Good morning, everyone. Today's talk will be on AC joint or acromioclavicular joint dislocations. Now, the AC joint is commonly involved in traumatic shoulder injuries, and the treatment of this type of injury has been a subject to controversy for many, many years, even from early medical writings. However, the treatment has also evolved and changed as our understanding of the nature and the problems with the biomechanics of the joint has developed. To start off, I'll talk a bit about the AC joint anatomy. The clavicle is the only bony structure that connects the upper limb to the trunk. The AC joint is a synovial joint between the distal end of the clavicle and the medial acromion. The AC joint has a capsule, which also incorporates the acromioclavicular ligaments, which are superior, inferior, anterior, and posterior. And they resist the anterior posterior translational forces of the distal clavicle. The superior AC ligament is the strongest of them all, and that blends with fibers from the deltoid and trapezius muscle. There's an articular disc or meniscus, and it's intracapsular, so between the distal clavicle and the acromion, and it's an incomplete disc. The AC joint is also stabilized by a strong accessory ligament, which is the coracoclavicular ligament, and that's a principal stabilizing mechanism. And this ligament also prevents the inferior or the downward motion of the scapula. There are two parts of this ligament. We can see in the diagram here. There's the trapezoid ligament and the coracoclavicular ligament. Sorry, the conoid ligament. The conoid one is posterior medial, and it's the strongest one of the two, and the trapezoid is anterior lateral. Now, the mechanism of injury is usually a direct blow to the shoulder joint. An example would that be a fall onto the shoulder with the arm adducted, as illustrated in the diagrams here. It is a common athletic injury, and the force drives the acromion downwards, or the acromion and scapula downwards and medially. The degree of damage to the AC joint corresponds to the joint displacement and the amount of ligament injury. This may result in just a sprain or a tear of the AC ligaments with upward subluxation of the clavicle. However, if the force is severe enough, the CC ligament or ligaments may also be torn completely, and if that happens, it's a complete dislocation. The classification of this injury, it's graded according to the amount of injury to the AC and CC ligaments, which relates to the degree of disruption between the scapula and the clavicle. Tossi and Ullman originally classified this into 3 grades. That was in the 1960s. However, this was later modified by Rockwood into 6 types in 1989. Types 1 to 3 were consistent with the older system. However, the subgroups of type 3 in Tossi's classification were recognized to require operative intervention. So there were different severities of this of type 3s. So that the type 3 was divided into 3, 4, 5, and 6. So type 1 injuries, it's just the AC ligament sprain. The x-rays usually appear normal. Type 2 injuries, the AC ligament is actually torn, The distal clavicle is unstable in the anterior-posterior plane or horizontally, and the joint may appear subluxed or widened with slight elevation of the clavicle, and that could be secondary to minor stretching of the CC ligament. And X-rays may show that the AC joint appears widened. In type 3 injuries, the AC and CC ligaments are torn, and there's 100% dislocation of the joint. The acromion is displaced inferiorly. The distal clavicle is unstable, both in the vertical and horizontal planes, so anterior, posterior, and upwards and downwards. And the AC joint is reducible in a type 3 injury. And the way you can reduce it is by applying an upward force while holding the elbow and pushing the upper limb upwards. Type 4 injuries, the clavicle is dislocated posteriorly, and it could be into or through the trapezius muscle. The anterior part of the acromion will appear prominent, and on X-rays in the axillary lateral view, you'll see posterior translation of the lateral clavicle. And in this type of injury, the AC joint is not reducible. Type 5 is 100% dislocation. So it's essentially an exaggeration of the type 3 injury, where the coracoclavicular distance is 100% more compared to the opposite side. So you need bilateral X-rays to compare and be able to see that. The deltoid and trapezius muscles and fascia are more extensively detached from the clavicle, and again, in this injury, the AC joint is irreducible. And finally, type 6 injuries, which are quite rare and require a large amount of force to end up with this injury. The distal clavicle is displaced inferiorly under the acromion or the coracoid process. And that could be a result of hyperabduction and external rotation. With this injury, there could be also multiple other fractures, either of the clavicle or the ribs. And again, this is an irreducible injury. Clinical features. With shoulder trauma, pain near the acromion and clavicle, we always need to suspect the AC joint injury. So on examination, we should have the patient standing or sitting with the arm unsupported, and that will allow gravity to pull the arm down and see if the scapula drops. Look for any local swelling, abrasions, bruising, deformity. Feel for any tenderness over the AC joint and also in the CC interspace. And examine the AC joint and distal clavicle and see if there's any, if there's a degree of displacement, and see what direction that's in. And also assess to see if there's any clavicle fractures. Movement will often be painful. Also assess the sternoclavicular joint for dislocations and a neurological exam as well. With type 1 injuries, because it's the less severe of the 6 types, there might be just minimal tenderness and swelling and minimal pain with arm movement. Usually there's no tenderness in the CC interspace because you haven't injured the CC ligament. Type 2 injuries, they'll probably have more pain. The outer end of the clavicle may be superior to the acromion, and there'll be some pain with motion. the distal end of the clavicle will be unstable in the anterior-posterior direction as well if you palpate it and assess it. Type 3 injuries usually probably a bit more pain. You'll be able to reduce the AC joint by holding the elbow and pushing the upper limb upwards. Type 4, essentially the same clinical findings as type 3, however the clavicle will, when looking from above, you'll probably see the clavicle sitting posteriorly in relation to the acromion. And also the clavicle, or the distal end of the clavicle, can become buttonholed through the trapezius and can tent the skin posteriorly. Type 5s, again exaggeration of type 3, and the clavicle will be much more prominent. Type 6, you'll probably have a flat appearance to the shoulder because the clavicle is sitting anteriorly and inferiorly. Investigations. Routine x-rays are the AP Zankov views, which are 10 to the 15 degree cephalic tilt, and axillary lateral views. Ideally, comparison views should be taken as well. Stress views are commonly used as well, which distinguish between type 2 and type 3 injuries. That's when bilaterally arms are placed at the side and holding a small weight, and this will essentially increase the distance between the coracoid process and the inferior border of the clavicle. A difference of 50% is diagnostic. Strike and notch view. So when you're suspecting that the coracoid process may be fractured, this is the X-ray which will show it. And so that's if the AC joint is dislocated, but you have a normal CC distance. You'd probably think of the coracoid process being fractured. And here are some images of the different X-rays. So top left is the AP X-ray. The axillary view or axillary lateral view. Top right is the Zankov view, and the strike or notch view. The management of these injuries. Type 1 and 2 injuries don't need surgery. Usually they're treated with a sling or a shoulder immobilizer for comfort. This removes the stress on the CC and AC ligaments, and could be required for 7 to 10 days in the type 1 and up to 14 days in a type 2 injury. Rehab and physiotherapy are important after the initial pain resolves. So gradual passive and active assisted range of motion, isometric strengthening and isotonic strengthening as well, with gradual escalation of the strengthening and endurance. Contact sports and heavy lifting should be avoided for the next 2-3 months, and that's to avoid the conversion of a type 1 or 2 injury into a type 3, which is a 100% dislocation where the CC ligament has been torn. Type 2 injuries can, if the pain persists after a type 2 injury, we can consider operative treatment. The type of surgery depends on the cause of the symptoms. And the options are, or I guess some of the causes are post-traumatic osteolysis of the clavicle, post-traumatic arthritis, recurrent subluxations in the anterior-posterior plane. The capsular ligaments can sometimes be trapped within the joint, loose cartilage, and a detached intra-articular disc. And the options for treatment depends on the actual problem. type 3 injuries, the role of surgery has always been controversial. Earlier reports supported operative management. A reason for this may have been because the initial classification was type 1, 2, or grade 1, 2 and 3. So grade 3 also included the more severe injuries, which in Rockwood's classification is 4, 5 and 6. So because you had the more severe injuries, the surgeons often operated on type 3 injuries. However, recently, after the Rockwood classification, there's been a tendency towards a non-operative approach for type 3 injuries. Recent studies show that there's no evidence that surgery provides better functional results compared to non-operative versus operative. With the non-operative approach, patients tended to return to normal function quicker than an operative approach, so return to work or return to sports. And with surgical intervention, there was a higher complication rate. Proper and adequate rehabilitation may be critical in the successfulness of non-operative management. And there's a relative indication which has also been described in the literature, is a young age job that, or a sport that places high demands on the shoulder, so overhead workers or overhead sort of throwing athletes. That has been a relative indication. It hasn't really been proven, and this theory has been challenged. There was an article by McFarlane where they successfully treated baseball players with a non-operative approach. That was in 1997. There also should be the consideration for late onset of AC joint arthritis in the non-surgically managed patients. Types 4, 5 and 6 usually all require surgical intervention. There's no real consensus on which technique to use, and there are a few available and a few that have been described. The first one is primary fixation of the AC joint, which is the hook plate. I think earlier they used to use K-wires, but there's been complications with K-wires where they would migrate into unusual places, like the lung, spinal cord, neck. So I don't think they use these much these days. But I've seen hook plates being used quite often, where the lateral end of the plate, the pointed bit here, is placed underneath the acromion and then pushed down onto the clavicle, and that reduces the AC joint, and bicortical screws are used to attach the plate to the clavicle. This can be combined with ligament reconstruction, or you can use the hook plate alone. This is mainly used for acute injuries. However, a second operation is required to remove the plate. Fixation between the coracoid process and the clavicle. So Bosworth popularized the use of a screw for coracoclavicular fixation. That was in 1941. The use of screw can be combined with suture loops, or a combination with ligament reconstruction, which is what Rockwood did. The screw, however, requires a staged removal. Placement of synthetic loops between the coracoid process and clavicle, with or without CC ligament reconstruction, is also another method, and that doesn't require, because it's not using a screw, it doesn't require screw removal. This is usually used in acute injuries, and some problems with it is a suture loop can cut through the clavicle or the coracoid process, and there have been problems with the screws as well, where they can back out or break. Ligament reconstruction, so which can be used in the acute or the chronic setting. Weaver and Dunn were one of the first to describe the use of the coracoacromial ligament to stabilise the AC joint. And this included resection of the in Weaver-Dunn's procedure. It included resection of the distal clavicle, and that was aimed to avoid late degenerative changes at the AC joint. The CA ligament is detached from the undersurface of the acromion, and that's transferred into the medullary cavity of the distal clavicle as it's been resected. And then two drill holes are put into the distal clavicle and attached through there. This gained popularity, and there were various modifications to this technique, where, for example, a suture loop or a coracoclavicular screw could be added to this technique, which provided protection while the ligament healed. Arthroscopic techniques are also possible. There were some problems, ligament pull-out, for example, but you can use a small piece of bone from the acromion and attach that to the clavicle. Now that's an illustration of an example where the ligaments, the CA ligament usually goes here, and that's been taken off and attached to the distal clavicle, and here they've got a suture loop protecting it. Hamstring grafts have also been used. A loop graft around the coracoid process and clavicle, and this can be combined with resection of the distal clavicle. Double-stranded or semi-tendinosus grafts inserted into the coracoid bone with tunnels, so into the coracoid and two tunnels into the clavicle have also been used. And there's also been the mention of tibialis anterior tendon allografts. And here's an illustration with the graft going through the holes in the coracoid and the clavicle. Outcomes, or surgical outcomes. The CA ligament transfer, or the Weaver-Dunn procedure, there's actually 25% of the strength compared to an intact CC ligament complex. So the addition of various suture loops or anchors can increase the overall strength. With screw fixation, there was a high complication rate with screw breakage and pull-out. However, anatomic reconstruction, or double bundled semi-tendinosus grafts, were shown to show anterior, posterior and superior stability, and that also provided the advantage of a scaffold for revascularization. Complications of AC joint dislocation, so from an acute injury, other associated injuries depending on the mechanism and how much trauma there was, brachial plexus injuries, coracoclavicular ossification, so heterotopic ossification where the CC ligament is, or osteolysis of the distal clavicle, and arthritis. With operative management, the usual, I guess, complications such as infection, fracture through drill holes, loss of fixation, metal failure, and the recurrent deformity, failure of soft tissue repairs, reaction to non-absorbable tape, and AC joint arthritis as well. With arthritis, in type 1 and 2 injuries, since they're non-operatively treated initially, later on they may develop degenerative changes. The articular disc and cartilage can often be injured. Initially, you can treat this with simple analgesics, non-steroidal anti-inflammatory drugs, steroid injections, rest, or alter one's activities. If that fails, an operative management is possible where you can excise the distal end of the clavicle. This could be done either via open or a arthroscopic technique. The main, I guess, the importance with this technique is to preserve or repair the capsule to enable AP stability. With types 3, 4, and 5, the rule is don't treat with an isolated distal clavicle excision, because it'll result with unstable and shortened clavicle, since the CC ligament is completely torn, and also as well as the AC ligament, and this needs to be combined with a stabilization procedure, and for example the Weaver-Dunn procedure or a CA ligament transfer. So the main points of this talk are type 1 and 2 injuries are treated non-operatively. Types 4, 5 and 6 need surgical intervention. However, type 3 has been controversial. The correct treatment is unknown. Most studies, however, don't show significant differences between surgery versus no surgery. A subset of overhead athletes and heavy labourers may benefit from surgery, and adequate rehab may be critical to the success of non-operative management. Reference.